Hello everyone, this is Dr. Sam and today we will talk about ovarian pathologies on ultrasound. We will compare the normal and abnormal appearances of ovaries. Starting off with the normal views of left ovary. In the longitudinal view, it is more wider and has multiple follicles, and in the transverse view it is taller and we can see the follicles inside the ovary. Similarly, for the right ovary, both the longitudinal and transverse views with follicles visualized. Starting off with the first case, ovarian cyst. These are anechoic, rounded, thin-walled with posterior enhancement, and they are usually more than 3 centimeters in diameter. Cumulus oophorus is a small cystic structure at the periphery of this dominant follicle, and it is a sign of ovulation. Corpus luteum is formed after the ovum is expelled into the fallopian tube, and it is a thick-walled structure. By using Doppler, we observe peripheral vascularity. This peripheral vascularity is called the ring of fire, and we can also have internal echoes which are inside the corpus luteum. A hemorrhagic ovarian cyst can occur from rupture of a corpus luteum or any other functional cyst. It has internal echoes due to blood products and absence of flow on Doppler. Hemorrhagic corpus luteum showing peripheral vascularity, that is the ring of fire, and it also has internal echoes due to blood products. Endometriomas, also known as chocolate cysts, have unilocular appearance. Unilocular means single compartment. These locules are compartments, so this one has only one compartment and it has thick walls, and these internal echoes like ground glass appearance, and it has cystic solid components. This one is cystic, slightly lower in echogenicity, and this is the solid component, slightly more in echogenicity. Serous cystadenomas have anechoic appearance and are unilocular. This is again one compartment, so this is called unilocular, and this one is anechoic as compared to the endometrioma, which was not anechoic. Serous cystadenocarcinoma is the malignant form. It is comprised of heterogeneous appearance and more solid components, and the patient may also have ascites. Mucinous cystadenoma is larger in size and has lots of locules. There are many locules in this. Mucinous cystadenocarcinoma is the malignant form and has more solid components and heterogeneous components. The walls of the locules are more hyperechoic. Dermoid cysts are also called mature ovarian cystic teratomas, are echogenic masses with attenuation, and they also have fluid levels. These are two different fluids with different densities. The dermoid plug, also called Rokitansky nodule, is a hyperechoic structure due to hair, tooth, sebaceous or calcific component. It is more likely to be malignant. The dermoid mesh is formed from hair inside a cyst, And this form gives a dot dash pattern. These are thin echogenic bands which give this type of appearance. Another feature is the floating ball sign, which are fat globules inside the cyst. These are hyperechoic fat globules inside a hypoechoic fluid. Ovarian fibroma is a benign tumor of the ovary. It is a solid hypoechoic mass which may sometimes have cysts. Ovarian thecoma is another benign tumor of the ovary, but it is non-specific on ultrasound and has variable appearance. Metastases appear as solid hypoechoic masses in the ovary, which give a specific moth-eaten appearance. They appear as these hole-like structures, and this type of metastatic lesions are also known as Krokenberg tumor. Paraovarian cysts are simple cysts outside the ovary, and they move independently when transducer pressure is applied. Polycystic ovary occurs when there are more than 20 cysts inside an ovary, and the follicle size can range from 2 to 9 millimeters. Due to multiple cysts, this gives a specific appearance called the string of pearls sign. Here we have the string of pearls sign. The cysts are lined up together and they look just like this string of pearl. In ovarian hyperstimulation syndrome, the ovaries are enlarged, which could be more than 12 centimeters. They have lots of cysts, and these cysts give a spoke wheel appearance. In ovarian torsion, the ovary can appear enlarged, could be more than 4 centimeter. There will be absence of blood flow on Doppler. Here we can see there is no blood flow inside the ovary when the Doppler is applied, and the ovary is appearing hyperechoic as well. A classic sign of ovarian torsion is the whirlpool sign. Because the ovary is twisted, it gives us this type of appearance, and this appearance is called the whirlpool sign. Using Doppler makes the whirlpool sign more prominent. As you can see, the shape of the structure is looking just like that whirlpools that we see in water. Another important sign which might be noticed in some cases of ovarian torsion is the follicular ring sign. It is a thick hyperechoic margin around the follicles which can measure 1 to 2 millimeters.
Hello everyone, this is Dr. Sam and this video is about uterus and ovaries ultrasound probe positions. On the left side is a schematic diagram showing ultrasound probe position. These dotted lines are the right and left costal margins. This is the umbilicus. This white box is the ultrasound probe, and this red dot is the indicator or the orientation marker. This is the inguinal region. At this point is the symphysis pubis. For scanning the uterus, we place the probe between the umbilicus and the symphysis pubis joint. This is the hypogastric region. It is also called suprapubic region. Place the probe in the midline in longitudinal orientation. The patient's bladder must be full for transabdominal scanning. After locating the bladder, you will find the uterus posterior to it. Here is the endometrium and this is the cervix. You can also rest one end of the probe on the symphysis pubis to get better views of the uterus. Tilt the probe accordingly to scan the uterus completely. For scanning and measuring the endometrium, try to keep the probe parallel to the uterus. Heel-toe movements of the probe can be performed to align the probe with the uterus. This type of angling towards the patient's head is heel movement. For an anteverted uterus or anteflexed uterus, you can use the heel movement to align the probe parallel to the uterus. For a retroverted or retroflexed uterus, use toe movement. The probe is angled towards the patient's feet, and this will align the probe properly with the uterus. To scan the lateral aspects of the uterus, move the probe laterally towards both the left and right sides and you will get this image. This is the lateral aspect of the uterus. Now we will see how to scan the ovaries. The ovaries don't have a fixed position, but locating the internal iliac vessels is a good landmark to locate the ovaries. First, we will see the right ovary. Move the probe laterally and slightly oblique like this to locate the right ovary. We will get this image. It is showing the ovary in longitudinal view. In a similar way, move towards the left side to scan the left ovary in longitudinal plane. We will get this type of image. This is the left ovary. Next, we will scan the uterus in transverse view. Place the probe in the midline and rotate it 90 degrees anti-clockwise to keep it in transverse orientation. Tilt it superiorly and inferiorly to completely scan the uterus from the fundus to the vagina. This type of image will be formed. We can see the uterus in the middle and also the right and left ovaries on the sides. Now move laterally in this manner to scan the right ovary. By using the bladder as a window, you will find the right ovary at this location. You can rotate the probe in an oblique orientation if there is some difficulty in locating the ovary. Now you can move to the left side to scan the left ovary in transverse view. This is the left ovary near the uterus in transverse plane. Thank you so much. Hello everyone, this is Dr. Sam, and in this video we will learn how to measure ovarian volume. The formula for measuring ovarian volume is as follows: 0.52 into length into width into depth. All these values will be in centimeters. These are transvaginal images. The measurements are more accurate in this approach. We take two measurements in the longitudinal view. The longest measurement is the length. One caliper is placed at the superior edge of the ovary and the other caliper is placed at the inferior edge of the ovary. The second measurement is the depth. One caliper is placed at the anterior margin of the ovary and the second caliper is placed at the posterior margin of the ovary. The third measurement is taken in the transverse view. that is the width. An example of ovarian volume is given here. 0.52 into a length of 3.4 centimeters multiplied by a width of 3.4 centimeters multiplied by a depth of 1.5 centimeters. These values correspond to average size of the ovary. This gives us a volume of 6.36 milliliters or cubic centimeters. Volume of the ovary can vary amongst individuals due to age, different body size, and height. These are transabdominal images of the ovary. This is the bladder. This will be the length, and this will be the depth. This image is in transverse view. The calipers are placed horizontally to measure the width. Ovarian volume is the largest in women under 30 years. An approximate volume is around 14 to 15 milliliters, but it can even go as high as 25 milliliters. Also, there can be a significant difference in volume between the normal right and left ovary. In women between 30 to 40 years of age, the volume may be around 30 milliliters approximately. Volume starts to decrease with advancing age. In women between 41 to 50 years of age, the volume can be around 11 milliliters. This image shows both the ovaries in transverse view. For women between 51 to 60 years of age, the volume is around 5 to 6 milliliters, and for women above 60 years, the volume can be around 4 to 5 milliliters. Here are more transvaginal images showing measurements of ovary. These are the length and the depth, and this is the width being taken in transverse view. These images are transabdominal images with caliper placements for length, depth, and width of the ovary. Thank you. Hello everyone, this is Dr. Sam, and this video is about ovary ultrasound reporting. In this video, we will see how to write reports for ovarian pathologies. We will only include the ovary. This is a report for normal ovaries. You can start by writing ultrasound examination of both ovaries shows normal size and shape without evidence of any abnormal masses or cysts. Then you can write the sizes of the ovaries. After that, you can write about their echotexture, and you can mention the follicles seen. After that, you can write overall the ultrasound findings are within normal limits and no significant abnormalities are identified. The first case is simple ovarian cyst. In the findings, you can start by writing the size of the cyst, and then you can write well-defined cystic lesion in the right or left ovary. The cyst has smooth walls and is filled with fluid. There is no evidence of any solid components or septations. The left ovary appears normal with multiple small follicles. This was the finding for this case. In the impression, you can start by writing, based on the ultrasound findings, the patient has a simple ovarian cyst in the right ovary. which is a common type of ovarian cyst. Then you can write about further evaluation. Also mention a follow-up ultrasound may be recommended to monitor the size and characteristics of the cyst over time. And then you must write about clinical correlation, as a diagnosis is not completely done on ultrasound alone. Now we will look at hemorrhagic ovarian cyst. The clinical indication in this case was pelvic pain. In the findings you can write the size of the cyst, and then you can mention internal echoes in the right or left ovary. The cyst has thick irregular walls and multiple septations. The internal echoes are consistent with blood products, indicating a hemorrhagic ovarian cyst. And then you can write about the appearance of the other ovary. In the impression you can write, based on the ultrasound findings, the patient has a hemorrhagic ovarian cyst in the right ovary. Then you must write, immediate clinical evaluation and management may be necessary. And after that you can write about the treatments such as observation, pain management, or surgical intervention, depending on the severity of the symptoms and the size and appearance of the cyst. Also mention follow-up imaging may also be recommended to monitor the size and characteristics of the cyst over time. This example report is for a ruptured hemorrhagic ovarian cyst. You can start by writing the size of the cyst, followed by the presence of internal echoes and a thick irregular wall in the right ovary. There is evidence of free fluid in the pelvis, consistent with a ruptured ovarian cyst. Then you can write about the appearance of the other ovary. This is the impression. The findings are consistent with a ruptured hemorrhagic ovarian cyst in the right ovary, with evidence of free fluid in the pelvis. Immediate clinical evaluation and management are necessary, including pain management and possible surgical intervention if the patient is hemodynamically unstable or if the cyst is persistently bleeding. Follow-up imaging studies may be recommended to monitor the size and characteristics of any remaining cystic structures. The patient should be referred to a gynecologist for further management. For endometrioma, in the findings you must mention the ground glass appearance of the ovary. Then you can write, the cyst has a thick echogenic wall with diffuse low-level internal echoes, consistent with an endometrioma. And after that you can write about the other ovary. In the impression you must mention the endometrioma, followed by clinical correlation, and you can write about treatment options. And after writing these statements you can write, the patient should be referred to a gynecologist for further management. This report example is of serous cystadenoma. There is a well-defined, thin-walled, unilocular cystic lesion in the ovary. No internal flow is detected within the lesion on color Doppler, and then the appearance of the right ovary is written. In most cases it can be difficult to conclude that it is a serous cystadenoma. So in the impression you can just write the features seen, and after that you can write about clinical correlation and further management. This report is of a malignant case, serous cystadenocarcinoma. In the findings of this case, you can write a complex cystic mass, and then you can write its measurement, and then you can write its location. The cyst has thick, irregular walls with solid components. There is also evidence of ascites and peritoneal implants. Such findings are highly suspicious for serous cystadenocarcinoma, and after writing these statements, you can write about the other ovary. This is the impression for this example. The patient has a suspected serous cystadenocarcinoma in the left ovary. This type of ovarian tumor is malignant and can spread to other parts of the body, such as the peritoneum and lymph nodes. It is important to mention additional imaging studies such as CT or MRI, and also the patient should be referred to a gynecologic oncologist for further evaluation and management. Now we will look at mucinous cystadenoma. These are the findings. A cystic mass is seen with thin walls and internal echoes. The cystic mass appears to be multiloculated with thick septations and internal debris consistent with a mucinous cystadenoma. And then the appearance of the other ovary is written, followed by the appearance of the uterus, and in the end there is mention of absence of free fluid in the pelvis. This is the impression. Based on the ultrasound findings, the patient has a mucinous cystadenoma in the left ovary. This type of ovarian cyst is usually benign but can grow to a large size and cause symptoms such as abdominal pain, bloating, and pressure. And then the line of clinical correlation is written, and in the end, referral to a gynecologist may be necessary for further evaluation and management. These are the findings for mucinous cystadenocarcinoma. There was a complex cystic mass measuring 8 centimeters in the left ovary. The cyst has thick walls, internal septations, and solid components with evidence of internal vascularity. There is also evidence of ascites and peritoneal implants suggestive of mucinous cystadenocarcinoma, and then the appearance of the right ovary, the uterus, and the endometrium are written. This is the impression. The patient has a suspected mucinous cystadenocarcinoma in the left ovary. It is important to mention additional imaging studies such as CT or MRI for evaluation and further management. Here is a case of dermoid cyst and its report. In the findings you can write a well-defined cystic mass, and then you can write its location, followed by presence of internal echoes and calcifications. The cystic mass contains heterogeneous internal echoes and speckled debris indicating fat and hair. consistent with a dermoid cyst. And then you can write about the appearance of the other ovary, the uterus, the endometrium, and the presence or absence of free fluid in the pelvis. This is the impression. After mentioning the dermoid cyst, you can write about clinical correlation and referral to a gynecologist for further evaluation. Now we will look at the report for ovarian metastasis. The clinical history was a 58-year-old female with a history of breast cancer, status post-mastectomy, and chemotherapy, presents with abdominal pain and distension. These are the findings. Ultrasound examination of the pelvis shows multiple irregular solid masses with irregular borders in both ovaries. Then there is the measurement of the mass. The masses have internal vascularity. There is also evidence of peritoneal nodularity and ascites. These findings are suggestive of ovarian metastasis, most likely from the patient's known history of breast cancer. In the impression, you can mention the patient has suspected ovarian metastasis. In this case, it was from breast cancer. Make sure to mention further imaging studies such as CT or MRI for further evaluation of the metastasis. Also mention referral to a gynecologic oncologist for further treatment and evaluation. This is a case of para-ovarian cyst. In the findings, there is a well-defined cystic mass adjacent to the right ovary in this example, measuring 4 centimeters in diameter. The mass is separate from the right ovary and has thin, smooth walls with no internal vascularity. In the impression, you can write, the patient has a suspected para-ovarian cyst. Observation with serial ultrasounds may be recommended to monitor the size and growth of the cyst. Referral to a gynecologist may be necessary for further evaluation and management. This is a report for polycystic ovarian syndrome. There are bilateral enlarged ovaries with multiple small follicles arranged in a peripheral distribution, giving the appearance of a string of pearls. Then the measurements of the right and left ovaries along with the number of follicles present are written. In the impression, you can write, the patient has suspected polycystic ovarian syndrome. Then you can advise tests to assess hormone levels such as FSH, LH, testosterone, and insulin. Then you can write about treatments such as lifestyle modifications, weight loss, and exercise, and other treatments. This is a report for ovarian hyperstimulation syndrome. Both the ovaries are enlarged and both of them have internal septations, multiple cystic structures. The endometrium was also thickened in this case, and there was mild free fluid in the cul-de-sac. In the impression, you can write, the patient has suspected ovarian hyperstimulation syndrome, and then you can write about further evaluation and management. The findings for ovarian torsion include an ovarian mass with a twisted vascular pedicle. The ovary is enlarged and there is absent or minimal blood flow on color Doppler. This can be concluded in the impression. The twisted vascular pedicle and absent or minimal blood flow on color Doppler imaging are diagnostic for ovarian torsion. It is important to write immediate surgical intervention is required to prevent further damage and preserve the affected ovary. And you can also write about management such as detorsion of the ovary with or without removal of the torsed adnexal structure. And in the end you can write referral to a gynecologist or general surgeon for urgent evaluation and management is necessary.